Chapter 4: Palliative and End-of-Life Care. Advances in technology during the past several decades have vastly improved the ability of healthcare providers to provide for the sickest patients and have led to increasingly successful outcomes. The appropriate use of these invasive and frequently expensive resources is still a matter of debate, and it leads to complex ethical issues in the care of a person with a critical illness. While there is that improved ability to care for the critically ill, they may be used inappropriately when a person has a very poor prognosis. And those use of invasive, costly resources in potentially futile situations can be extremely controversial. There are areas of progress, however, such as in the increased education for healthcare providers. There's also more opportunities for growth and improvement, such as the fragmentation of care, increasing healthcare costs, and end of life education. Patients in the critical care unit are unable to make decisions about their own care. Thus, they rely on surrogates to decide for them. These surrogate decision makers frequently rely on factors other than the prognosis communicated to them, and increasingly the likelihood of conflict in situations. Multiple factors influence the continuation of aggressive care in the face of a poor prognosis, including provider differences, provider comfort with difficult conversations, and patient and family beliefs. Patients and surrogates often do not understand the ramification of their choices, and nurses play a key role in ensuring that the choices are understood. These can be preceded by withholding or withdrawing addressive support, and decisions made by surrogates often are not based on the diagnosis. The outcomes of the decision are not well understood and can be a highly stressful environment. The nurse plays a key role in explaining these choices to the patient and family. The identification of the dying patient is often subjective and based on the healthcare provider's opinions and interpretations of the patient's response and results. This makes the determination of the appropriate intensity of care for the patient near the end of life extremely difficult. There's going to be many key terms throughout this chapter, such as non beneficial care, which results in a quality of care that would not meet the patient's goals. Inappropriate care, this would be care that has no reasonable expectation of the patient surviving beyond the acute hospitalization, or the patient's neurological status is such that the patient will not perceive the benefits. There could also be potentially inappropriate care that may result in the proposed outcome, but there are competing other situations. There could also be futile interventions, and these are interventions that are unfortunately not achievable. A lot of these will relate back to your own clinical judgment. In situations when care and treatment may be considered non beneficial, inappropriate, potentially inappropriate, or even futile. Conclusion is this life saving culture continues to drive aggressive care, even when it becomes obvious that the ultimate outcome will be the death of the individual. Significant progress has been made in the medical legal arena in establishing the rights of patients and surrogates to devise for themselves the intensity and duration of care. Unfortunately, patients die of distinct illnesses that could be potentially curable. Dying is often viewed as a failure on the part of the system or providers. And the purpose of the healthcare system in the United States is to treat illness, disease, and injury. Many clinicians experience personal ethical conflicts when providing painful interventions and aggressive care to patients when they believe the situation is futile. These conflicts can cause significant moral distress that can lead to burnout. There's everything from ethical conflicts, moral distress, as well as the concern for the patient's dignity. Dimensions of end of life care. Nursing in the critical care setting at the end of life is focused on 5 dimensions. These 5 dimensions consist of alleviation of the distressing symptoms, communication and conflict resolution, withdrawing, limiting, or withholding a therapy, emotional and psychological care of the patient as well as their family, as well as caregiver organizational support. Palliative care has expanded beyond the scope of hospice where it was introduced. Palliation is the provision of care interventions that are designed to relieve the symptoms of illness or injury that negatively impact the quality of the life of both the patient and the family. They're there to provide comfort and designed to relieve those symptoms, and should be implemented with all patients, not just the dying. Common distressing symptoms include pain, anxiety, hunger, thirst, dyspnea, diarrhea, nausea, confusion, agitation, or sleep disturbances. These palliative care interventions can take many forms, such as frequent repositioning, good hygiene, skin care, the creation of a peaceful environment, and pain relief. There can also be a holistic approach to palliative care, such as the early identification of end of life patients, pain management, pharmacological as well as non pharmacological interventions to relieve pain, control anxiety, as well as other distressing symptoms. And you should involve palliative care clinicians in the plan of care. In the case of communication and conflict resolution, you should provide clear, ongoing, honest communication, as well as incorporate shared decision making. Allow time for family members to express themselves, agree on a treatment plan, and facilitate continuity of care. Communication between members of the healthcare team, patient, and family should occur shift to shift between healthcare team members as well as between patient care units. When withholding, limiting, or withdrawing therapy, this usually precedes the most critical care deaths. Death does not constitute euthanasia or medical aid in dying. Euthanasia is illegal throughout the United States, though MAID is authorized in areas of the United States. It depends state by state. The portable medical orders, or POST, is mutually agreed upon by the patient, proxy, or their surrogate provider, and clearly specifies care at the end of life. When preparing to withdraw treatment, you should provide anticipatory guidance to both the patient and the family. Anticipate distressing symptoms and medicate to relieve those symptoms. Also, titrate the therapy to relieve emotional and physical distress. Terminal weaning can be the titration of ventilator to minimal levels, as well as the removal of the ventilator, but not the airway or endotracheal tube. Each facility is going to have its own policies and procedures to consult. Most withheld or withdrawn medical interventions, called terminal weaning or terminal extubation, they may also involve titrating pain medications and sedation during this process. This helps to relieve the tachypnea, dyspnea, and use of accessory muscles. Other commonly withheld therapies include vasopressors, antibiotics, blood and blood products, nutritional support, and possibly even the deactivation of implanted devices. The nursing action priority is to ensure the comfort of the patient during this process. In the case of palliative sedation, this is inducing a state of decreased or absent awareness in the patient, though it is monitored and use of medications with the intent of relieving the burden of an otherwise intractable suffering. It is not intended to cause a patient's death, and many providers and institutions will vary on their policies. Hospice care can be given in a multitude of environments, everywhere from inpatient, at home, acute care, freestanding hospice that may be more tranquil environment for the patient. These facilities emphasize comfort rather than cure, and view dying as a normal process. The philosophy of care, not the location, is common in oncology and is appropriate when aggressive interventions are withdrawn. Hospice is a model of care based on comfort measures. After the decision to withdraw or withhold therapy, we want a smooth transition of care to hospice, including thorough communication and family and patient involvement. In the case of emotional and psychological care, there are viable interventions based on the patient's and the family's needs. They're non judgmental and culturally sensitive assessments. They have family involvement, spiritual counseling if appropriate, clear and concise information, bereavement counselor, and listening to their life story. Coordinating the communication process among the patient, family, and the healthcare team is key nursing action. The nurse should make time to listen to family accounts of the patient's life before the illness or injury and acknowledge the patient's individuality and humanity. Quick quiz. The nurse assesses there is significant disagreement among family members about what course of treatment is best for the patient. What is the best response by the nurse? Would that be A, you need to come to a decision quickly and let us know what you want? B, perhaps you should consult with your pastor or priest? C, could we hold a family conference so that we can discuss the best plan of care for you and your loved one? Or D, which one of you is the patient's surrogate to make the decisions? And that answer is going to be C. Holding a family meeting and directing the focus onto the patient is the most therapeutic nursing intervention. The other statements either put pressure on the family members to immediately come to agreement or refer the family to another healthcare provider, which is inappropriate when the nurse is working with the family. End of life care requires a significant amount of the nurse's time. Other staff may assume some duties of the nurse. The administration provides support for staffing, space for family meetings, and assistance with funeral arrangements. They also hold educational sessions for the public about end of life issues and life support options. Educate the nurses regarding palliative care and end of life interventions. The caregiver organizational support should take many roles, everything from adequate staffing, co-worker support, conduct family meetings and develop a plan of care, assist with funeral arrangements, educate the public, and professional development classes. Cultural competence is going to play another key role in end of life care. Most clinicians, unfortunately, feel ill prepared, and cultures will differ in their death practices. Cultures differ in both end of life option selection, and becoming familiar with the common cultures in this service area could be a major benefit. You also want to become familiar with religious groups and beliefs about end of life, while taking into consideration individual preferences as well. Most importantly, we want to create a safe environment, allow for inclusivity, ask and don't assume, allow for unbiased care, and make a patient preference driven decision. Another quiz. The nurse is preparing the patient for end of life care. The families express the patient is devout in their religion. How should the nurse proceed? Would that be A, call the chaplain to assist? B, discuss with the family about what will be important to the patient at the end of life? C, notify the respiratory therapist that it is time to proceed with terminal extubation? Or D, prepare to administer palliative sedation as ordered? That answer here is going to be B, discuss with the family. While it may be appropriate to call the chaplain, the nurse should first discuss the patient's wishes with the family. This plan of care should be addressed prior to withdrawal. Also, prior to initiating palliative sedation, the nurse will want to address the patient's wishes, as there may be constraints on which medications can be used due to religious beliefs. Some key points and takeaways from this chapter is to ensure the patient and family needs for communication, information, support, and comfort are met. Moral distress may occur when it's non-beneficial or inappropriate interventions or treatments are provided. Nursing self-care is also important. Palliative care is an integral part of high-quality, personalized critical care. Establishing trust and rapport enables a safe environment for discerning what is most important to individuals at their end of life. And finally, frequent nursing assessment and collaboration with a multi-professional team. This ensures appropriate symptom management. Critical care nurses must simultaneously be aware of the patient's physical needs, as well as their cultural, spiritual, and personal needs. Ongoing nursing education on palliative care and end-of-life topics is important. End of life, it's going to be a very difficult situation, both for the family as well as the nurse and providers. And unfortunately, death is the only certainty in life. We do everything we can for them, and unfortunately, it's going to be a very difficult practice, no matter where you're working in nursing. But anyway, that's all we got for this chapter. I'll see you in the next slides.